Hello, friends. Let's talk about anticoagulation issue in our uh, day-to-day hematology Bleep. Um, you may have seen that sometimes you receive call from ED or from other medical departments that the patient is on treatment dose anticoagulation for some reason, like VTE, and the platelet count is low. So, what should we do with the anticoagulation? Okay. I think this is a common question from the other team that low platelet and anticoagulation, what should we do with that? First, ask them why the patient is on anticoagulation. They may say that the patient has a clot history. Ask them recent or long-standing history of VTE. What I mean by recent, if it is less than 4 weeks or if it is more than 4 weeks time, because we know that from the BSH guidelines, if the clot is within 4 weeks time, then we have to support the patient with platelet transfusion to keep it above 50% for therapeutic doses of anticoagulation, both normal pyruvate heparin and DOACs. If the patient is um, out of this window, means his VTE is more than 4 weeks ago, then yes, you can adjust the doses of his anticoagulation. Ask them why the patient has low platelet count. Is there any treatable cause for low platelet? Because if it is ITP, then it's difficult to raise platelet count above 50, even with platelet support. If the patient is on chemotherapy for hematological reasons or for solid organ cancer chemotherapy reasons, then it is a bit difficult to raise the platelet count above 50, even with support. Maybe the cause of low platelet count is infection, antibiotics, hematinic deficiency, maybe platelet clumps even. Better to ask them to repeat the saturated full blood count. So if there is any modifiable cause, then yes, then you can tell them once the cause is over, the platelet count will come up. But if the platelet count is hanging around 50, 50 to 60, then it is better to convert DOACs to low molecular weight heparin. Because if the patient bleed on DOAC, you don't have any antidote for DOAC except for life-threatening GI bleeding, apixaban and rivaroxaban. But if the patient bleed on low molecular weight heparin, then you can use protamine to reverse the effect. And also, low molecular weight heparin has a small half-life than the DOACs. So the chances of damage to the patient is less with low molecular weight heparin. So if the platelet count is on lower side, like for example, between a range of 50 to 60, better to convert DOACs to low molecular weight heparin therapeutic doses if the patient is having VTE uh, in the last 3 months of time, out of the window of 4 weeks. If the patient platelet count is above 30, then yes, you can use prophylactic doses as well in which there is no VTE. But if there is a history of VTE, then the guideline says that you can use intermediate doses of low-molecular heparin as well if the platelet count is between 30 and 50. So better to see what is the trend in the platelet count, if it is coming down or not, and what is the cause of low platelet count. Most of the trust guideline says that if the platelet count is above 30, you can use prophylactic dose. If there is a history of VTE, you can use intermediate dose. But if the platelet count is above 50, then therapeutic dose is safe and prophylactic dose is safe. So just to recap again, if someone call you that my patient is on um, therapeutic doses of anticoagulation and the platelet count is on lower side, what should we do? Ask them why the patient is using low molecular weight heparin and what is the indication of anticoagulation in this patient. If they say VTE, when was the VTE? Less than 4 weeks or more than 4 weeks? Less than 4 weeks, can we support this with the platelet transfusion? or not. If more than 4 weeks, then you can adjust the dose of low molecular weight heparin in this patient. First, convert DUOC to low molecular weight heparin, and then if the platelet count is above 50, continue with treatment dose of low molecular weight heparin. But most of the consultant, what they do to use a safe approach, they split the dose of low molecular weight heparin when the platelet count is 50 to 60 range, because it is the platelet count is very low. There are chances of bleeding. You split the therapeutic dose. For example, patient is on 14,000 unit tinzaparin. We divide it into two, 7,000, morning and evening. This is a safe approach as well. If the platelet count is between 30 to 50 and the patient is having a VTE history as well recently, then you can use intermediate dose. Some consultant would say prophylactic dose. Better to read your trust guideline about that. If the platelet count is less than 30, no anticoagulation. In cancer-associated thrombosis, the guideline says that if the platelet count is less than 25, no anticoagulation. So it depends whether your patient has cancer-associated thrombosis or thrombosis because of other reason. You can adjust the doses of low molecular weight heparin. Sometimes the patient has no VTE history, and you may receive a call that this patient has low platelet. Can I give prophylactic doses to my patient? Again, first read your trust um, guideline, what they says about the prophylaxis. I know some trust in the UK which says that give prophylaxis if a platelet count is above 50. Some trust says give prophylaxis if the platelet count is above 30. Our approach is to give the prophylactic doses of heparin if the platelet count is above 30. So it depends on trust and trust to trust policy as well. But usually, the safe approach is that when the platelet count is on lower side, like between 50 to 60, split the therapeutic doses into two. If the patient is using, for example, 14,000 unit, as I have mentioned earlier, divide it into 7,000 and 7,000. If the platelet count is between 30 and 50, and it is unlikely to go above 50, use intermediate dose for your patient. If the platelet count drops below 30, then it is usually uh, advisable to avoid anticoagulation. But if your patient has a VTE clot recently, a week back or 2 week back, or within 4 weeks, then you cannot say that I will stop anticoagulation if the platelet count is less than 30 or if it is less than 25 in cancer-associated thrombosis. You have to support your patient with platelet transfusion. If you cannot make the platelet count above 50 with platelet transfusion, then yes, then use intermediate dose or use split dose depending upon your hospital trust. So this question is quite common in our day-to-day calls in the hematology, that patient has low platelet count and patients are on anticoagulation. What should we do with the uh, anticoagulation? So we will be discussing such coagulation cases or other hematology cases from Registrar Bleep from time to time. If you have any suggestion or if you have any question, you can put in the comment. We will discuss that as well. But I usually carry the Registrar Bleep, and I have these questions, and I will discuss a case a day if possible. And your suggestions are also welcome as well. Thank you.